Hey, it's Jessica DaMassa with WTF Health. I'm here at AHIP's Consumer Engagement and Digital Health Forum, and joining me right now I have Dr. Seth Feuerstein. He is the former Chief Innovation Officer at Magellan, and he still does some consulting work there. He's on faculty at Yale, and he's just launched a new startup that is focused on suicide prevention. So Seth, welcome. It's good to talk to you.
It's great to talk to you.
All right, so you said to me, and I love this. I love this mindset, and I want to know more about it. So you had said to me that as far as diseases of the brain go, you believe that software will be to diseases of the brain what genetic testing has been to cancer. So talk a little bit about that. Break that down for me.
Sure. So when you think about cancer care evolved over the last 30 to 40 years. First, unrelated to treatment, 30 to 40 years ago, even longer, cancer was something people didn't talk about.
Right.
And then as information started to come out, now when someone's diagnosed with cancer, culturally we embrace that person embraces the condition, generally speaking. And I think diseases of the brain, mental health, neurologic diseases are similar, that people didn't talk about them. It was this whisper thing. To some extent that's still the case, but famous people are coming out discussing their problems. Famous people unfortunately are dying by suicide. When you think about cancer, genetics really revolutionized the field. All of a sudden, while we still talk about breast cancer or thyroid cancer, ultimately the clinical community talks about the genetic signature of that cancer, and that's how you decide what to do. When you think about the brain, and this may sound like it's dehumanizing, but it really isn't. The brain is essentially an information acquisition, processing, and distribution center. Okay. So when we move a limb or when we say something or we think something, the brain is essentially where we take in information, think about it, and then distribute impulses. Software actually is uniquely positioned to measure that, to ping it, send in interventions, and then track how you're doing. Okay. And so software really, I believe, will become the platform around which we work with people that are struggling with conditions that affect the brain.
Okay, so I'm guessing that this is kind of the underlying thesis behind the company that you've just started that's focused on suicide prevention.
Correct.
All right, so how are you guys doing that? Because this is a really heady concept, and I think you're onto something here, but I'd like you to kind of bring it down a little bit for us. So tell me a little bit about how that your new company works in order to do this and prevent suicide.
First, we're bringing all of the stakeholders to the table.
Okay.
So in healthcare, one of the things, and I've been fortunate to be successful, but one of the things that I think has been a limitation is that people don't reach across silos enough. Okay. So we're bringing together key nonprofit stakeholders, the best researchers, and we've already done this, as well as our expertise in software app development and diseases of the brain. So we're working with chairs of psychiatry and psychology, presidents of universities, nonprofit that runs the National Suicide Lifeline. So that's number one, key stakeholders.
Get them all together.
Number two is don't leave out any piece of technology. There's no one right answer, and there's no replacing humans. Okay. So on the one hand, people don't get access to proven care for suicide prevention. On the other hand, it can be delivered to them and non-dehumanizing using technology. So one piece of it is telehealth related. Okay. It's bringing validated care to people who need it where they need it. The other is digital applications that are proven and studied like drugs that actually help people who are struggling with suicidal thoughts, suicidal actions, and risk of death by suicide. We bring them together, we build them into the healthcare ecosystem in a way that people are comfortable integrating them and paying for them. And that's kind of the macro vision.
Okay, that last part is really the secret sauce here, because that's usually where a lot of digital applications, or like a lot of the startups who are trying to apply technology to solving some big healthcare challenges, fall apart. It's usually on that point of integrating it into the system and finding somebody to pay for it. So you came from Magellan, and you're still doing work with Magellan. So tell me a little bit about, what do other innovators out there need to know about how to do this in such a way where they can achieve some sort of success?
Yeah, it's really hard, and I was very lucky. So I had a digital therapeutics company. We were lucky to be successful, fortunate to become part of Magellan. Yeah. Phenomenal organization, amazing people I learned a tremendous amount from. Magellan has a pharmacy benefit management division. Magellan has a very well-known behavioral health division. They do radiation treatment management, they do musculoskeletal management, they have their own health plans for Medicaid and Medicare dual eligibles. So being on the inside and working on improving things for all of the people we were responsible for, all the stakeholders, was invaluable, because I got to understand how are things paid for, and it's different within each of those businesses and even within parts of each of those businesses. And then when you took sort of the background I had and some of my team members had in digital apps and mental health care, bringing those together puts us in a really interesting position to try to impact change. And we take the view that, so suicide is a top 10 killer in the United States. It's been increasing in its prevalence in the United States for 2 decades. Wow. Other conditions in the top 10, like cardiac disease, have been coming down. And here we have this very important problem. And I think part of it is that it's a subspecialty within mental health care. And psychiatrists and psychologists are often not adequately equipped to handle it. For instance, I'm sure your listeners and viewers have this experience. I call my doctor at 6 p.m. with a question, and we all get the same message. The office is closed. If this is a true medical emergency, dial 911. Now, the first question is, who's ever called their doctor's office with a true medical emergency, which says something about the way the system is structured.
That's true.
But the second is, data shows us, and this is just one example among many, patients who are at risk for suicide, they are most likely to have an attempt in the middle of the night when you pick time of day. If you're going to pick a time of day when they're most at risk, well, the system isn't designed to help them, but technology can bring providers to them, not necessarily crisis providers, because the United States does a lot in terms of crisis on that front, but actual care providers who are their doctors, who have their medical record and who can be on the phone with them at 2 a.m. talking to them or texting with them or having a video session with them. Does that make sense?
Yes, but the question I have on that is, why is it important for them to be talking to a medical provider at that point?
Well, there are different types of clinicians.
Right, and no, totally, I get that. That's why
it doesn't have to be a medical provider, but it has to be someone whose knee-jerk reaction isn't go to the emergency room before really understanding what's going on. It's a costly problem for both the people who are responsible for paying for their care as well as them and their loved ones and their caregivers. The digital application is really designed around behavior change, understanding the situations you're in, using very well-validated protocols, and studying the app like you would study a drug. There's actually no product approved by the FDA for suicide prevention. So for this population, there's really nothing that doctors today can prescribe.
I mean, what's interesting to me is I'm thinking to myself, suicide prevention. So does this mean that someone has already attempted? Or does it mean, where in the, the mental health spectrum here, of I'm depressed, and then it crosses over to that, where it's I need suicide prevention, I'm having suicidal thoughts. What is that trigger for you guys?
Well, one important distinction is the distinction between depression and suicide risk. Okay. It's true that a lot of depressed patients do end up at risk, but suicide is really more about hopelessness and less about depression per se. Okay. It's not that they're not related, but they are related, but they are distinct. The second is, I'm trying to remember. The second part is trying to teach them to deal with that situation. And so it might not have to be a medical provider. It could be that there's somebody that they know to reach out to who cares about them, who's a friend or a family member or a peer. And so digital tools are really good for that. We've seen what they do socially, and we can talk about the potential pitfalls of social media and things like that, but you see how technology can connect people, and that's really important for, we believe, this particular patient population. I think one of the challenges with people who aren't yet known to be at risk for suicidal behavior is identifying them. And we don't have the data yet to really know who they are and how to efficiently do things for them. So you have to start somewhere. We're starting with people who actually are known to be at risk, who either have had a previous suicide attempt or very serious thoughts of suicide.
So I want to go back full circle here to the beginning of this conversation, which is about software being kind of like this silver bullet that can really help in terms of all sorts of diseases of the brain. So give me a little bit of a, predict the future for me. So where do you see this going, and what other conditions, not necessarily even mental health, because you were very specific about calling it diseases of the brain. So how do you feel like software can help with some of, and what diseases are you talking about?
So I think this will end up being true across all of healthcare. Okay. We've done studies in my previous company. You can look at a condition like OCD, obsessive compulsive disorder. We did studies showing that patients actually prefer to use the software, certain large groups of them, and they do just as well as they might do with a clinician. But if I was to say to you, if someone has a cardiac condition, let's say I have heart disease, what's really more important for my outcome? Is it whether or not I take a medication, or is it my behavior? It's sort of a rhetorical question. We all know it's like my behavior. Am I exercising? Do I eat well? Those are the things that have a huge impact on my cardiac status. It's not that Lipitor doesn't help a lot of people, but it's that the behavior in the end is more important. I think we're going to do a better job with software focusing in on conditions that are very specific from a behavioral perspective, and then extending those learnings to other diseases. There are a lot of companies making significant progress, though, with things like heart disease and diabetes and prediabetes using software-based approaches and combining them sometimes with live clinicians. So it's not to say you can't make progress in other areas of healthcare, but I think starting with mental health care makes a lot of sense because you can measure significant changes in patients. And we've seen, insomnia is an interesting example. We've seen shockingly good data. A study on our software program for insomnia that Magellan now uses in all different types of care settings and with other payers was published in a journal called Sleep. It's the leading academic journal. It was a randomized controlled trial, and it basically showed that the software worked just as well as seeing a live expert clinician in delivering therapy for people who have trouble sleeping. It worked better than the meds that are FDA approved, and we've had success with it out in the marketplace.
Do you think we're going to run into the same problem that with like artificial intelligence and machine learning? There's like all that clamoring about like radiologists being out of jobs because the machines are just going to be able to read the scans and be able to do a better and more effective job. Do you think we're going to run into a similar problem with physicians and using software in this way to kind of help either mitigate or triage or even treat some of these different diseases?
Well, it depends on who you are if it's a problem.
Okay.
I would say this. In 10 years, I can say with certainty that in 10 years, I'm pretty certain I'm going to rather have software reading my chest x-ray than a person. I think 10 years from now, it's safe to say that software is going to outperform. That doesn't mean there isn't a role for clinicians. So when we did our last company, and what Magellan does now is not take jobs away or important work for behavioral health clinicians. Actually, it allows them to allocate their time to the more complex patients that need that, or spend less time with the patients who can get a lot of benefit from the software.
It's about acceptance and adoption. I mean, it's kind of at the heart of my question is like, it's like, are we going to have physicians who are going to be accepting it and, utilizing some of these tools in the same way that they're, comfortable using their current, or do we have to wait for a generation of doctors to just retire?
Yeah, I mean, look, loneliness is important, right? I don't think you're really going to see software replace human interaction in the way that some people are predicting, at least not in my lifetime. And I'm a kind of a futurist when it comes to this thing, and I still don't think so. There's nothing like that human interaction. I think when you think back to the 1960s and the 1970s, before sort of the healthcare industrial machine became what it is today, primary care doctors spent a lot of time with their patients.
Yeah, they went door to door with a little black bag.
And they were often my grandfather was an internist, and I used to go with him around an urban area, and he'd see the whole family. He'd chat with them. He knew them. Mm-hmm. When they were on the phone with them, he knew if they needed to go to the emergency room. That was invaluable. Sure, people are living somewhat longer today, although in certain demographics, things are getting, are pretty bleak, actually, in certain sub-demographics in the United States. But that was incredibly valuable, and you're seeing emerging digital care models that are actually leveraging this kind of human interaction, building a pyramid of care. I think what I can say is that today you have this pyramid of care where physicians might sit at the top, and then you've got PhDs and social workers and peers and all that. I think what you're going to see is the pyramid flip upside down. And software will enable for the immediate triage to sort of lots of people who are good people, may not have the same amount of training as the most expensive professionals have, but those most expensive professionals won't be the front edge, the front line of seeing those patients because there'll be ways to filter them. They'll be able to spend more time with the patients who need them more.
Seth, this is cool. I mean, I think this is a really, obviously I think this is kind of all the direction that we want healthcare to take. So thank you so much for stopping by and sharing your perspective with us. Awesome to talk to you.
It was truly my pleasure.
Thank you. I'm Jessica DaMassa with WTF Health here at AHIP's Consumer Experience and Digital Health Forum. Thanks for joining us.